Dr. Liz Plowman is a physical therapist, author, a disability advocate, living with a neuromuscular disorder herself. Drawing on 15 years of clinical experience in her book, Some Spoons Are Worth Spending, she helps people with energy limiting conditions move safely, confidently, in ways that truly support their lives. So we're so fortunate that Dr. Plowman is with us today. And with that, I will pass it over to Dr. Plowman.
Hello, and thank you so much. I am absolutely honored to be here for this wonderful organization and for your very first LEMS Learn. I'm honored that I get to join you for this one. Um, so I am thank you for the introduction, Madeline, and again, thank you for having me here. So I'm going to talk about navigating physical therapy with LEMS, which is it a fun challenge in and of itself, but hopefully you come out of this with it a little bit demystified. So let me go ahead. I'm going to um, share my presentation. All right, so we're navigating PT with LEMS. This does have real-time closed captions. Disclaimer, the closed captions don't always get it completely right, so take that for what you will. If it doesn't quite get my words, especially medical words, it doesn't always get those right. But if the closed captions help you, that's why I do have them on. So let me advance my slide. There we go. So a little bit about me. I am known on the internet. It's scary to be known on the internet, but apparently I am, as the myasthenic PT. I have a doctorate in physical therapy from Texas Women's University. I did postdoctoral study in neuromuscular junction disorders at Texas Tech University, and I am also a person living with a myasthenic condition. Now, I have MG, which I'm fully aware is not LEMS, but I feel like we are sister or at least cousin conditions here. We have a lot of overlap. So it does give me some professional scope into LEMS. I am the author of Some Spoons Are Worth Spending. So basically, a lot of my patient education time that I spent on educating folks with neuromuscular conditions on how to conserve their energy and why, I basically took all of that and put it in a book. And that is the book that I went ahead and put out. I am a now I don't I'm out of private practice. I now really just spend my time educating and advocating for people with chronic diseases with energy limiting disorders. I am medically retired from the US Navy, which I'll talk about more here in a little bit. I am married. I have kids. I have dogs. My dogs think they're kids. And in my copious amounts of free time, I am a novelist, a four-time published novelist, an entrepreneur, travel enthusiast, foodie, Star Trek fanatic, trivia addict, and coffee addict, because with all of that I have to be. So that's a little bit about me. Disclosures, like I said, I am the author of a book. The book does generate me revenue. It funds my coffee addiction, is what it does. But that being said, I have no other disclosures. I am not here. I'm here purely for the benefit of this organization. I am here to teach about physical therapy, about navigating that with a neuromuscular disease, and that is my purpose for being here. I'm not trying to sell workshops, courses, anything like that. I am here to educate, and that is why I'm here. All right, so objectives. We're going to talk about what the heck is physical therapy, because some people know it really well. Some people, it doesn't have a good, a wide knowledge base, I think, awareness base of what it actually is. We're going to talk about the benefits of PT for people living with LEMS. We are gonna, at the end of this, you should be able to confidently select, or know how to navigate PT, how to pick a PT that's going to be right for you in a practice setting that's going to be right for you. Have the tools to self-advocate for your specific needs within that system as a person living with LEMS, and learn a thing or two and have some fun. So, quick little introduction, and there are neurologists who have probably spoken to you. I love the neuromuscular population because I feel like we're some of the most medically literate people that there are, because we have to know about our conditions. So this is a quick little just overview, you live with this condition every day, so you know what LEMS is, but just for housekeeping's sake, right? It is a rare neuromuscular condition. It causes fatigable muscle weakness. That is the hallmark of the myasthenic conditions. So muscle weakness that fluctuates. It affects how nerves and muscles communicate. And I love to use the analogy of a cell phone. So, because most people can relate to that. And feel free to steal this from me when you are trying to educate people about what you live with every day. So I like to use the analogy of a cell phone. You have the tower that is functioning, the cell phone tower. So that's the nerve. It's functioning, it's transmitting. You have the phone, which is on and fully charged and not broken because my kid didn't get a hold of it. So it's fully working. The problem is you're trying to call on one bar of signal, and that signal fluctuates. And so that is where the neuromuscular, the myasthenic conditions come in, MG, LEMS, CMS, etc. I love to use that analogy on how to explain it. And so, like I said, feel free to steal that from me when you're trying to explain what LEMS is to other people, friends, family, colleagues, etc. In LEMS, we most often see the proximal muscles affected, and that means muscles that are closer to the core of the body. So typically the hips and the shoulders. Weakness commonly starts in the legs. I say that lightly because everyone has a different journey and everyone has a different experience with the condition, but that is kind of the top of the bell curve, if you will. It can make daily activities harder, things like walking, standing up, or changing positions, sit to stand, going up the stairs. You can have involvement of the eye, facial, and swallowing muscles, but you typically see that presentation more in MG than you do in LEMS, but there is overlap of the conditions and you can see that in LEMS as well. But what you do see in LEMS that you don't see in the other myasthenic conditions are autonomic symptoms that make this condition rare. The rare group I makes this a rare condition within a rare group of conditions. And that one often gets overlooked. So we get things like dry mouth, dry eyes, lightheadedness when standing, and that is a definite concern. Okay, so what's PT, right? So it's a healthcare profession, and it is focused on improving mobility and quality of life. So I don't know about you, but I like moving and I like living a life that lets me do activities that I want to do. So that is what the entire profession of PT is, in a nutshell, is dedicated to. It involves lots and lots of things, and I'll get into the weeds on that in a little bit, but we have lots of tools at our disposal. So that might be exercise, that might be manual therapy techniques, different modalities, different pieces of technology, and we treat a wide range of things. But basically, we're helping regain function, manage pain if that is an issue, improve strength, flexibility, and then move better. So that's PT. So LEMS changes the way we move. PT helps people move better. So I feel like we're a good match here. But there's a lot of misinformation. So I love this. These little image grids were popular probably about 10-ish years ago, but I still love this one the most. So this is kind of PT, right? What my friends think I do, what my mom thinks I do, right? Society thinks I'm a massage therapist. My patients think I'm a drill sergeant, and they can probably attest to that. Um, then there's what I'm thinking I'm doing, and then paperwork is what I really do. So I just throw this in for humor value, although there's a whole lot of truth to it. But the point being that it's a profession that, right, there's no, at least to my knowledge, there's no Netflix series about PTs. There's no, we might get into a medical drama as a little side character, helping someone walk in parallel bars, and that's all you see of PT in the media. So a lot of people, right, don't know what it is. All right, so I'm going to pause here and go into my story. That is me once upon a time. And so I served I was an active duty physical therapist in the Navy. That is me. The poor guy who's posing for this picture hated me because he had to do about 25 of these push-ups to get the photograph. Um, but I was a staunch orthopedic PT, so bones, joints, muscles, that's what I loved. I love to work with spine, with shoulders, with knees, with backs, with hips. I was a manual therapist, so if I could twist you into it, oh wow, okay, I'm getting reactions behind me. I'm talking with my hands, and Zoom is giving me fireworks. Okay, great. Um, but basically, if I could take a patient and twist them into a pretzel and get a couple pops, pop, 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 and get them back out to duty, I was a happy PT. If you had asked me at that point in my career if I wanted to work with people with neurologic diagnoses, I would have very politely and professionally told you no. But then the universe had a good sense of humor. And I was about 3 months postpartum after having my first child, my daughter, and I all of a sudden I was weak in ways that I couldn't explain with just being out of shape from and recovering from pregnancy. So, I used to be able to get on the ground and pop out 10, 20, 30 push-ups. I couldn't do three. And then I couldn't do one. And then I couldn't go up the stairs. And right. And so that happened. And like so many of us, I got into diagnostic pinball and I was finally diagnosed with myasthenia gravis. Um, and it basically, in a nutshell, as it progressed, meant that I could no longer practice PT in the traditional sense. I could no longer twist my patients into pretzels. I could no longer, get on the Bosu ball with this guy and do those push-ups with him. It affected my stamina. It affected my ability to even strength test to do any of that. So I couldn't stay in the military and I couldn't stay practicing PT like I was. Um, so it radically changed my life on a personal level. It did mean that I was medically retired from the Navy. And it meant that I had to figure out how I was going to continue practicing a profession I loved in a different way. Um, so I became the patient, which was humbling, because PTs need PT too. And so now I'm entering my own profession as a patient. And I did. I had a few very knowledgeable PTs because I can tell you from having gone through PT school, and then I did teach on faculty at Texas Women's University after diagnosis. That was part of my professional journey, post-diagnosis professional journey. I went into academia. Um, I can tell you that when I went through school in our one of our neurology classes, in the lecture on rare diseases, I got half a slide on myasthenia gravis. Never mind LEMS. And I'm surprised MG even got half a slide. And so I was diagnosed with this condition, and I'm thinking to myself, like, wait, I remember a note about that somewhere in school. And so I had to get smart really fast. So all of that to say that in general PT school, these conditions, if they are taught, they're glossed over. And not because they're not important, but because these programs are training PTs to be generalists. They're to be entry-level generalists, go out and treat the population, and they are trained to treat the most common neurologic diagnoses. They're trained to treat stroke, spinal cord injury, Parkinson's, um, vestibular dysfunction, so vertigo, that sort of thing. And then we do talk about some of the other conditions, but right, they are really taught and trained on how to treat what they're most likely going to encounter, because their chances of encountering someone with post-stroke versus someone with LEMS, I mean, the numbers are what they are. So as a PT and as a person living with a neuromuscular disorder, I had to get smart real fast. I worked with a few PTs who were knowledgeable, but on a whole, as I navigated the system as a patient, I was spending way too much of my time and energy educating other PTs about my condition, as I'm sure you have that experience as well. Um, Now, I had the benefit of understanding what was going on in my body and how quote unquote normal physical therapy had to be modified for someone with a myasthenic condition because we don't respond this our muscles don't respond the same way as the rest of the population. Um, and but most people who have myasthenic condition aren't PTs, so they don't necessarily know how to navigate PT. So all of that to say, that is why I am so passionate about this topic of putting the tools in into your hands. So I love this little bit, right, about medicine adds days to life, PT adds life to days. So that is all about the PT gets us back to being able to functionally do the activities that we want to be doing. Medicine opens up the door to basically drop the barriers to strengthening, to training, to relearning these activities. PT is what actually gets you doing the activities. All right, so let's kind of revisit this, right? What's a PT? And this is per the American Physical Therapy Association. That's our national organization. We are movement experts, optimize quality of life through prescribed exercise, hands-on care, and patient education. We teach patients how to prevent or manage their conditions so they'll achieve long-term health benefits. So the big thing I want you to take away from there is movement expert. A PT, and this is kind of what's lesser known, all 50 states in the United States, physical therapists are doctoral trained. So that is, it didn't used to be that way. Before it was a master's degree, before that it was a bachelor's degree, and then way back in World War I, when we started, these were converted nurses or on the job trained folks. But now we are all doctoral trained. So we've gone through 8 years of school, and then many of us go on to residencies and fellowships as well. So we have a lot of subspecialties. And this is one point, and I put the slide on here because there's a misconception that all PTs are the same, but we specialize just like physicians do. And I think a lot of times when docs prescribe, say, okay, go see PT, and you're thinking, okay, well, or it's maybe the clinic that's written down, or it's a general clinic. It might exist in a strip mall, right? Those are typically going to be very orthopedic focused clinics or general clinics. They are generally, now not always, but generally speaking, a more complex neurologic diagnosis isn't going to be treated sufficiently at a clinic like that. Because the folks in there are either generalists or they're orthopedic, more often than not. But like I said, we have many subspecialties. We've got orthopedics, we've got neurology. I started out as an orthopedic board certified specialist. I switched gears and got my neurologic specialty. We have geriatrics, pediatrics, oncology, pelvic health. The list keeps going on and on about all of the specializations. So kind of like you wouldn't go to the cardiologist to be treated for your LEMS, we need to go to a neurologic focused PT to treat to address LEMS. You're going to have a better chance of getting someone who understands the condition. All right, so top priority of PT, number one is safety. Absolute number. So why we go to PT, top priority is safety. So this is where we're working on things like fall prevention, recovery, balance training, fixing your home environment to make it safe. So that is priority number one. Priority two is mobility. And I love this picture, by the way. I know it has nothing to do with LEMS, but I love that picture of moving and doing things that we care about. So that would be things like walking, choosing an assistive device, right? Because not all assistive devices are created equal. So there's walkers, there's canes, there's crutches, there's wheelchairs, there's rollators, there's all sorts of things, and making sure we got the right if you need the help, we got the right device, and it's properly fit and you're trained on how to use it. Because I can't tell you, it's like playing bingo for me, is to go out in town and see how many people have devices that are not fit for them, or they're using a cane on the wrong side, or it's the wrong height, or they were never trained on how to walk with it and they're walking like Dr. House, wrong with the cane. Um, so it, to get the most out of a device, the training from a PT is vital here. And then we also look at functional movement. Let's make things easier. So going from sit to stand, moving around in bed, getting in and out of the car, etc. So we work on mobility. We also work on activities of daily living, or ADLs, or your ing activities. So dressing, grooming, bathing, toileting, all of the ing things. We have a lot of overlap here with occupational therapy. So occupational therapy works a lot on exactly this, these activities of daily living. And there's a lot of professional overlap there. And a lot of times we will co-treat. So I will, if I'm treating a patient and they're having a lot of trouble with some of these very specific activities, I might bring in an occupational therapist colleague to address, like, okay, what's the best way to brush my teeth? What's the best way to save energy in the shower, etc. And we also, energy conservation is huge, huge, huge for the myasthenic condition. So budgeting your energy, budgeting your spoons. I have an entire separate presentation that I frequently asked to do about conserving energy. We talk about pacing and spacing activities, modifying activities, and doing, little like life hacks, etc. Things, basically anything that we can do to make an activity cost less energy so that we don't burn out by the end of the day. So things like that. That is another benefit of working with a PT. And then we want to maximize available muscle strength. So a PT is going to be able to step back to analyze your movement, to assess how you're using LEMS affected muscle groups and muscle groups that are not as affected by LEMS. And then the idea is that we're going to maximize the available strength that you do have in the affected muscles. And we're going to strengthen and train unaffected muscles to be able to give you good compensations. And so that is a definite benefit to working with a PT, and that is not something that you can get off of YouTube. All right, so when do we see a PT? So there's three major times that I would recommend someone with a neuromuscular condition to see a PT. And one is either early in onset or after a major exacerbation. So basically kind of when you're at your lowest, right? And the focus here is safety, function, and mobility, right? So keeping you working on balance, keeping you safe in your home, keeping you from falling, getting you the right assistive device, getting you moving, getting you doing your activities. So in a way that is safe and helping you either recover from that exacerbation or maximize the function that you do have. When LEMS is well controlled, this is a great, so when you've got you've worked with your neurologist, you found that perfect blend of medication that basically has you at peak energy, peak available strength in your muscles. And at this time, this is where we really focus on rebuilding muscle strength and endurance. So basically, when the medication helps take those barriers down, then we can do the active exercise and targeted activities to build strength back up in that muscle. We can increase physical activity and then optimizing mobility and function. So in the early stage, if we got you walking, in the second stage, this is where we get you doing those activities you want to do. If you wanted to downhill ski, if you wanted to, I'm using that as an example, and not everyone is going to be there, but the point is, right, walk and then fun. And this one doesn't get thought of a lot because, right, we're so, I mean, this condition takes up a lot of our lives and a lot of our mental energy. But we still have human bodies that are subject to everything that other human bodies are subject to. So we also get back pain, knee pain. sprain your ankle, um, you name it. And so there are other conditions that may require physical therapy. So post joint replacement is going to require physical therapy. After surgery, chronic back pain, those things are going to require going to a PT. But even though you wouldn't necessarily be going to the PT for LEMS, LEMS is a big factor in how you're going to respond to PT. And um, so that's why that's on here, and it's still important to know how to navigate the PT system, even if you're not necessarily being treated for LEMS, if you're being treated for something else. All right, so let's talk about navigating PT. So these are some special considerations for how to get the most out of physical therapy. So one, choose the right PT. Easier said than done, I know. Um, So you want to work with a PT that has experience with neuromuscular disorders. And I use the balloon term there because, right, remember I talked about in lecture, right, when I went through school, hopefully it's changed. I know when I was on faculty, I advocated that we got more time on the slides. Um, but it, you want someone, if they haven't heard of the myasthenic conditions, or they kind of remembered it sort of from school, or they haven't worked with someone with with a myasthenic condition yet, you want someone who at least understands our cousin conditions. So that would be something like MS, Guillain-Barré, post-polio, although that's going, I mean, those are fewer and far between now, but basically people with a neuromuscular type disorder, so different from stroke, which was a brain lesion, but someone with that neuromuscular type disorder. So, like I said, MS, Guillain-Barré, and ALS. If they understand how to work with those conditions, then they are better equipped to be able to work with the neuromuscular junction conditions, which is where myasthenia falls in. Um, and I put this on here, working with a board certified neurologic clinical specialist, or NCS is the letters that you'll see after the name. And I put a question mark there, and I did that for a reason. Certifications are great, but at least I can speak in the PT world, to get that certification, that's very specific certification, is extremely expensive and not generally covered by employers and not compensated. And so just because the person doesn't necessarily have the letters simply doesn't necessarily mean that they are not educated and have the neurologic expertise. They may just not have been able to afford the thousands of dollars that it costs to take the exam and get the letters. So I've worked with plenty of great neuro PTs who just don't have the NCS because they couldn't afford it, not because they weren't qualified. So that's why I put a question mark there. Um, when you are, if you get referred to PT, ask to speak to a PT before scheduling with them. Ask for a discovery visit. Ask for a phone consult, to something like maybe 5-10 minutes of their time, just to talk to them. If the clinic will not allow you to do that, move on to the next clinic. Um, and and I put this on here, judge after the second appointment. And I say second because more often than not, if you start working with the PT, the first visit is evaluation. The first visit is, what can you do? What can't you do? Where are the deficits? What's been going on? Let me get to know you. If you are working with someone who has not worked with LEMS before, or even the myasthenic conditions, um, give them the benefit of the time between visit 1 and 2, because a good PT will go get smart real fast. A good PT will do a full evaluation that first visit and will say, okay, wow, I think I remember this from school. I do know how to work with the neuromuscular conditions, but let me go dive into the books and get really smart on LEMS. Then when you come back to visit 2, they should have a wealth of knowledge. They should have taken the time to improve their clinical expertise. If they didn't, move on. But that's why I say, for us to judge someone after the first visit, for a diagnosis that they have probably never seen in clinical practice is rough. Judge them after the second. And if you're not comfortable working with your PT, it is okay to change. It's like hairstylists. If they give you a bad haircut, get a different hairstylist. It's a it's a professional thing. Um, you're not you're not going to hurt any feelings, and if you do hurt their feelings, then they need to work on their professionalism. So that's a them problem, not a you problem. Get the treatment you need. And I did that myself. So when I first started getting treated after diagnosis, and I went to I went to a PT clinic, and the first visit was okay, and then the second visit we just weren't clicking, and that's where I pulled back and I said no, no, we're not going to do another visit together. I need to see someone else who can work with this condition better. And it's not an easy conversation to have, but ultimately it's the right conversation to have. And and it doesn't have to necessarily be directly to the person, right? It can be to the clinic manager, it can be to reception, it can be to somebody else. But yeah, don't if you don't click, change. And then also choose the right clinic. So there are now there are clinics, it's not on the slide, but there are clinics that we're seeing more of them now that are neurologic clinics, which is amazing. That we're seeing entire PT practices that are devoted to care of neurologic conditions. Um, so I mean, depending on where you live, if you're in a larger metropolitan area, you're going to have more access to that. If you're in a smaller rural area, you're likely going to have more generalized type clinics or clinics that see a little bit of everything. Um, but choose a clinic with a good accessible location. All right, can you access the building easily? Can you, especially if you have mobility issues, right? What's parking like? Is it okay? I can park close, but it's up on the third floor of the building, and it there's hard, it's difficult to access. So look for that. Um, the general atmosphere of the clinic. So different clinics are going to have different feels depending on the patient population that they're targeting. So a very sports forward clinic is going to feel like a gym. It's going to have that rubberized floor. There's going to be those motivational athletic posters everywhere. Um, it's going to be a very high-paced, fast environment, lots of moving parts. That's great for some people, not for others. Other clinics are going to have that more kind of calming, serene, healing atmosphere to them. So choose somewhere that's going to be comfortable for you. And then amenities. So, and I put two on here and specifically. Aquatics is wonderful for the neuromuscular conditions because it allows us to move in the water with buoyancy, and it allows us to exercise the muscles without the pull of gravity on them. And so it's aquatics can be a very, very powerful tool for LEMS. And then there are also body weight supported treadmills. So on the slide, the bottom right, that gentleman who looks like he's on in a bubble on the treadmill, that is a harness that basically so that treadmill weighs you, and then that harness, if I can say, okay, I want to move at 50% of gravity, that harness will lift and allow you to basically takes 50% of the weight off. And those are, they're not cheap, but a lot of the neurologic clinics have them because it allows you to train the muscles like the water. It allows you to train the muscles without the stress of gravity on them. So I put those on there. Those are not absolute have to have, but those are good pluses for conditions like ours. You also want to think about payment. And I'm going to say this in kind of broad terms because everyone is in a different financial situation, and I understand and respect that. But a lot of clinics are moving away from insurance into private pay, especially if you want one-on-one care. And if that is something that your budget affords, that is going to get you generally a higher level of care. um, if private pay is something that you can afford. Insurance, most insurances, absolutely. I think all insurances cover physical therapy. There may be restrictions on them, but just kind of know your policy, know your plan, and then make sure if insurance is what you want to be using, make sure the clinic takes it. There are clinics that will kind of do a hybrid, so they will bill your insurance for a certain level, and then they will do services that are generally not covered by insurance but are beneficial on top of. So you might get some paid by the insurance and then additional services that are beneficial on top. So it's you're getting that higher level of care, but you're not having to pay as much out of pocket. So just different things to think about there. 10 years ago, it was just insurance or nothing, but there are a lot of different payment models out there um, to to better meet needs. And then there's also non-traditional clinics, which I love. So there is virtual PT or telerehab. And that is near and dear to my heart because I was a virtual PT or a telehealth PT before COVID made it cool, before COVID legitimized it. That is actually practice-wise, personally, that is where I went after diagnosis. I learned that virtual PT was a thing, which allowed me to continue practicing in a way that was easier on my body. And it also allowed me to reach people outside my little geographic sphere who needed services that I could provide. So you are, if you're living with an energy limiting condition and the getting in the car or mode of transportation, going to a PT clinic, traipsing across the parking lot, getting into the building, sitting in the waiting room, you may have spent your energy for the day doing that. And then now you've got, 30, 45 minute, 60 minutes, depending on the session time, um, of activity with PT when you're already burnt out, and then you have to reverse the process and go home. So sometimes depending on where you are in the condition, going to a brick and mortar clinic may not be the best use of your energy. Where virtual can meet you where you are and can also give you access to professionals that are not within your immediate geographic location. So can give you access to those expert professionals who know how to work with the neuromuscular conditions. So I throw that out there. It's gained a lot of traction, especially increasing accessibility to PT. It just, COVID launched it, but we've really maintained it, and it's a great resource. I'm a little biased because that's how I chose to practice, but I really believe it's a great resource for us. There's also mobile PT, so it's still outpatient, so it's not considered home health, but it is a PT that does come to your house. And then there's concierge models too that basically kind of pay a monthly membership and you get what you need. So there's a lot of non-traditional versions out there as well. So getting the most out of your appointment, right? So these are just some general guidelines. Madeline, how am I doing on time?
We are at 1:40.
Okay, I will zip through so I can. Okay, I am toward the end.
Yep.
I'm a couple more slides. Thank you. All right, so getting the most out of your appointment. So with LEMS, right, you have times of day where you feel better. Either your medication is fully active. You have kind of peak times and valley times. So generally speaking, physical therapy is going to be a physically strenuous type activity. So you want to if you can, schedule it at the time of day where you are typically at your highest energy level. So for me, that's about 10 o'clock in the morning. It's different for everybody. Um, but just kind of know, right, when is your medication the most effective, depending on what you take. When do you feel your best? Take your medications as prescribed. Let your PT know if timing affects how you feel. So if anything might affect your blood pressure, if anything might affect, give you that dizziness when you stand, etc. You want to plan your activity and energy for the rest of the day. So keep in mind, PT is going to take is going you're going to spend energy on PT. So that is not the day to go department store shopping and walk through 5 stores. um, that do that a different day. So you want lower energy activities for the rest of the day. You want to tell your PT about your LEMS treatments, any recent medication changes, and so important, communicate with your PT. So your PT can see what your body is doing. Your PT can see if you start compensating and using other muscles. What your PT cannot see is how you're feeling, is if you start to feel fatigue in your muscles, if you start to feel lightheaded, if you start anything that you are feeling, your PT cannot see that. So you have to communicate it. Um, and oh, I switched the order of my slides, so bear with me. A few things about exercise, safe exercise. And these are things that I generally educate a PT on. So, and this is where, kind of self-advocacy comes in too. This is a great list. And I will share these slides, by the way. So if you are going to PT, this slide right here is a great list to take and say, hey, PT, these are my exercise guidelines. So one, you want to start ridiculously easy. You want low impact, low resistance activities, right? To start with, activities should feel very easy. You want low repetitions, low sets, and very important, lots and lots and lots of rest breaks. So whether you feel you need it or not, you want to break those activities up with lots of rest breaks. Generally speaking, to start, no extra weight is required. Now, again, everyone's at a different place. But generally when we start, your simple body weight activities should be enough strain and stress on the muscle to get them to work and activate. If you are doing swimming or aquatic type exercise, you want to stay in the shallow water, because muscle fatigable weakness can come on like that. So if you're in deep water, that is not the time you want your legs to quit working on you. So you also use a flotation aid, and never alone. Cycle through movements and body regions to prevent fatigue. This also known as circuits. So, or relative rest. So this would be, I'm going to do an exercise for my shoulders. And then the next one, I'm going to switch in and do an exercise in my legs and let my shoulders rest. So, and we're going to cycle back and forth. So there's now no such thing as arm day or leg day. We're cycling. Do not be fooled by the LEMS surge before initiating exercise, when initiating exercise. So it's very common in LEMS, and it's just very specific to LEMS, where you see when you start to exercise, you kind of get this surge of strength, and then it goes away. Make sure that your PT is aware, especially if this is something that you do experience in your presentation of it. When you start exercising and you feel that initial surge of strength, that I feel really strong now, that is not where you're going to stay. And so just to be aware, both you be aware of it, and then also make sure your PT is aware that you're going to experience this kind of surge, but it's gonna plateau out. So just being aware of that. And then super important, stop before you're tired. Great way to communicate with your PT and in a language that they understand is the RPE, which is the rate of perceived exertion. And this is basically how hard you think how hard you feel you're working. This is a standard measure that if the PT didn't sleep through PT school and pass their board exam, they should know this scale. So, and so basically it's, and I'm not going to go through every little detail here, but really we want to be targeting, when you're exercising and doing activity, we want to be targeting this 4 to 5, the grain, right? So it's moderate activity. You feel like you're doing something, but you feel like you could keep doing it. You're not feeling any of the increased fatigue signs. You're not feeling any shortness of breath. You can hold a short conversation. That's where you want to be. If you start really getting out of breath, or those muscles really start giving out, that's where you're getting into yellow and orange and red, and you don't want to be there. So you want to target this green, this 4 to 5, RPE of 4 to 5. So it feels like you can exercise for long periods of time, able to talk, hold short conversations. That's the level you want to be at. This is another communication tool I love using. with PTs, with between patients and PTs is the traffic light. I also recommend using it with yourself when you check in. Where are you? So green is that I'm in that 4 to 5. So back on this slide, 4 to 5, I'm green or better, right? I can keep doing this. I'm not feeling an increase in symptoms. Keep going, but just like when you look at a traffic light, you want to check in. So if you're driving down the road and the light's green, you don't just say, oh, all right, it's green. I don't care about it anymore. Whew, I'm going to keep driving. You keep checking it because eventually that light will turn yellow, right? And you'll need to stop. So it's the same with your body. So green is go, but keep checking in. Yellow is slow down, and it's where you get ready to stop. That's where you start feeling increased symptoms, increased weakness. Um, Red is basically where those muscles give out on you. And red is an absolute stop. So people ask me the difference between yellow and red. Yellow, you still have a choice. Yellow, you could push through if you wanted to and then pay for it later. Don't do that, by the way. Red, your body doesn't give you a choice. Those muscles are done. So that's the difference there. This is another great communication tool with your PT. Like, hey, color, check in. I'm green. Hey, PT, I'm yellow. We need to stop. We need to scale back. That's another good communication tool. All right, take home points. All right, so basically PT can absolutely help people with LEMS. We can build strength, we can move better and safely, and generally have a better quality of life, do the activities that we enjoy doing. We don't let LEMS win. All right. Care plan with PT, absolutely custom tailored. It needs and communicate really, really well with that PT. And PT can work well in conjunction with medication interventions. Remember, medications drop the barrier, and then PT lets you rebuild that strength and get back to retrain those activities. All right, so if you want more, these links will all be clickable. I am on social, not as active as I want to be anymore, but I'm there, I promise. And there's email as well. And that is the book that I wrote. It's for MG, but it's very translatable to LEMS, really any of the energy limiting disorders. So that is the book, right? And that's me doing the activities I want to do, and that's my daughter doing better push-ups than I can do. So, um, but anyway, so
Well,
that is it.
thank you so much, Dr. Plowman, and so many great points. I know I was taking notes for future resources on our website and everything. We did have some questions that we've gotten through the chat, and we'll start asking a couple, but just encourage any of our other participants to send some through the chats. When you first started talking about kind of finding your local or finding a physical therapist, you gave some great hints on, trying to find a neurological based. Is there like a um, society, like where they have a website of like the neurological based physical therapist where you could try to find someone in your area? Would that just be a quick Google search? And then if it's not a neurology or PT, I know we talked about certifications are a great thing, but like what are some things that you would ask or interview your physical therapist for, or what would you want them to have?
Okay, those are absolutely great questions. In theory, yes, there's a database, and it's called it's findapt.com.
Okay, we can look that
I
up
think
just to
I
verify.
think I think it's .com. It's through the American Physical Therapy Association. Now, that being said, it's not a complete, it's a voluntary registry of
Mhm.
where PTs are encouraged to go and say, this is where I practice, these are the patients I see, everything. So it's not necessarily complete because PTs have to respond to you have to be a member of the gay PTA, have to respond to the email and have to go put their information in. So take that for what you will. But it's a good place to start, I think, of being able to look for neurologic PTs because you can filter.
Mhm.
And that's through the American Physical Therapy Association, find a PT, pretty sure it's .com. So that's where I would go there. Second, in interviewing a PT, or even when you call in and you're talking to reception, even before you've gotten to that point, one, I want to know, well, first I'm going to look on the website. That's the first thing I'm doing is I am looking at the website to see like the conditions listed that they treat. Now, good luck finding LEMS on there. Good luck finding MG specifically listed on there. But like I said, you want to look for some of the cousin conditions. So you want to look for MS, Guillain-Barré, and ALS. Those are those are our cousins, if you will, in the
Mhm.
neuromuscular world. Because if a PT can treat those, it is very easy for them to translate to MG and LEMS and CMS. Um, so yeah, so when I'm talk when I do call, or if I'm going to say, hey, I need to work with a neurologic PT, if they are NCS, I still want to know, right? Okay, do they primarily work with stroke or spinal cord or neuromuscular, right?
Mhm.
Where, because you want someone use the words neuromuscular. Um, and again, right, even if like if they've treated if they're familiar with this condition, boom, you hold on to that person. You have found your unicorn.
Yeah,
Otherwise, ask about those sister conditions or cousin conditions.
great. Perfect. We also had another question about kind of can we speak to any tips specifically related to the decreased or absent reflexes, which are very common in LEMS as opposed to MG?
So those are generally speaking that is a clinical finding. It's not generally something that we treat. That's not something that's going to be corrected clinically. I think that's just something that the PT does need to be aware about aware of. I can talk uh, when they do the if they're doing a full neurologic exam, it should include reflexes,
Okay.
and that they should be aware that reflexes are more likely going to be diminished, and that is simply a clinical finding that is associated with LEMS. It doesn't generally affect how we train muscle performance, though. It is a neurologic finding that we are going to find. It's not something that we can't correct that in the
Okay.
clinic.
And we've also had a kind of question about hip pain. And is
Mhm.
there a connection between like a physiological, I can't speak either, so it must be going around that causes hip pain in LEMS?
So I I'm really glad you asked that question because I actually did the focus of my postdoc work was on pain presentation in the myasthenic conditions, because there's controversy about that, and I'm going to give you my very well researched opinion, which may differ. I'm just going to leave it there. I got a video taken down because a neurologist in Ukraine disagreed with me, but um, you know what? If my video was cool enough to make it all the way to a neurologist in Ukraine who disagreed with me, oh, great, great. Um, so, strictly speaking, pain is not a primary symptom of the myasthenic conditions because it has to do more with the muscle weakness. That being said, um, it is not uncommon to see it as a secondary or tertiary symptom because think about what's happening, right? If you have muscle weakness in the hips and there are certain muscles affected more than others, that's going to create an imbalance on the joint. And you have an imbalance on the joint over a longer period of time. You have compensation, so you might have changed the orientation of the joint. So, like, for example, a lot of times I see people start toeing out and kind of doing a shuffle walk because of hip weakness, right? That out toeing is going to cause certain muscles to be shorter. It's going to cause certain muscles to be weaker and stretched out. Plus, you have the LEMS weakness on the muscle, and then that puts an abnormal strain on the joint. Once or twice, fine, as a compensation, but you do that again and again and again and again, you're going to see what we call repetitive strain. And so, absolutely, I think you can see hip pain with
Mhm.
LEMS, just because of right the LEMS affected weakness and the compensations that happen because of it.
Yep, that is a great answer. Thank you very much.
I could see in
So
the chat, how is that a controversial opinion? I know it seems like common sense to me too, but I think what was there's big. Okay, I'm gonna be say this really nice and professionally. Uh, the general consensus is that the myasthenic conditions do not cause pain. I disagree. There we
patient.
go. That's me professionally.
Yeah, yes, perfect. And I know we've gotten some questions about is there a remedy to strengthen the hip muscle? And we've talked about, just to be completely transparent, doing another workshop, kind of talking through maybe some exercises and such that would be beneficial to the LEMS, more of, some ideas versus just kind of how to navigate. But would you be able to give us just an idea of a couple? And I do have a couple more
Absolutely.
questions too.
Absolutely. So I'll just kind of speak to more answer that question, like can we strengthen or can we not?
Yeah.
To get into specific exercises would way take me beyond time because I'll keep going and I'll start pulling out like my stuff back here. So um, but one thing is right with medical management, right? It allows us, like, it drops the barrier, as I said, and allows the muscle to get it allows us to access the muscle better to actually strengthen those affected muscles. Um, and we can also, yes, those muscles can be strengthened. First of all, with good medical management to kind of drop that barrier, and and then really specifically targeting those muscles. But we also want to make sure we're targeting the unaffected muscles too, so that they are picking up the slack for when the limbs affected muscles start fatiguing.
Mhm.
But there have been some really cool studies done, looking at, right, can we actually strengthen muscle? So can we increase muscle girth? And the answer is yes. They did an ultrasound study, and it was after a 6 month exercise program. This was in MG, not in LEMS, but the concept would absolutely still be the same. Um, and they found that yes, after 6 months in doing a very low load, low rep, lots of rest, targeted strengthening program with good medical management, you did see an increase in girth in the muscle. So yes, we can.
Wow. And then there was just one other question, but I'm going to add in something here. Someone asked, is it common to need PT every year? And is that sometimes a conversation between you and your doctor, and also what your insurance will allow? I'm sure sometimes PT for our community, if you are able to get it every year, is a nice benefit. Any thought there?
Um, so as a PT, I would say yes. Um, No, that being said, one thing that we are trying to make very standard in PT practice is the idea of an annual check-in. Just like you go see your dentist once a year for, like, hey, how are my teeth doing?
Hmm.
Right? That you have an annual check-in with a PT, to see basically how are things moving. And especially in a condition like limbs, I would absolutely advocate. Does that mean you need a full course of treatment every year? No. But a good check-in to say, okay, how are my muscles performing? How is my stamina? How is my strength? How are my compensations? How is my walking? Do I need to fix anything right now? I think that is definitely beneficial. And then everyone is kind of at a different place in the condition too. So some people may need more care than others. Some people that check in, you're good to go. Call me if you need me is sufficient.
Great. And then actually, I'm sorry, we got another good question in about someone who lives in a rural area and only has one clinic available. How could we find like teleconferencing, like you mentioned? Is that available through the findapt.com
Sometimes,
or
yeah.
okay.
So it should, and I forgive me, I haven't been to that website in a while since the last time they bugged me to update my info. It's the last time I've been. But at least I do recall there was the do you provide telehealth?
Hmm.
And a lot more clinics do now, especially they found that they all provided it during COVID because that's the only way we made money.
Yep.
It's the only way we stayed open. But they found that, hey, we can actually serve a larger chunk of the population and we can provide this care. So a lot of clinics maintained some semblance of a telehealth piece. So that is something that is a lot more accessible to us now. It might be on the Find a PT or maybe on the clinic's website.
Perfect. And then my last question is kind of one to you as an MG patient. I
Mhm.
think you had a really good point of like the three times that you would suggest going to see a physical therapist. And the last being is when you have pain outside of LEMS. And how do you,
Yep.
as an MG patient, kind of say, like, this is my MG, or this is, I hate to say this word, but like aging, or this
It's a
is,
great word. It is a wonderful problem to have.
yeah, like, how do you kind of discern like what you're going to blame on your MG versus like, this is something else and this is what I should be looking into?
Okay, fabulous. So first of all, I don't know if this is exactly what you asked. I will answer your question.
No worries.
Um, when I am, because I've done this, I have PTSD, PT2.
Hmm.
I'm horrible at treating myself. I'm horrible at it. So I will go to my friend and colleague. Um, and I've gone for different things. I've gone for neck, for back, for other things. And be the squeaky wheel. Because if they're not, you have to speak up about, okay, hey, you want me to do this exercise, you want me to do 30 reps, not happening. MG is not allowing it. LEMS is not going to allow that. Let's break that into sets and let's sparse that with other. Let's put that into a circuit so that my body can get relative rest and not get overly fatigued. So I get the benefit from your treatment without flaring my condition. Be the squeaky wheel.
That's
Absolutely be the squeaky wheel advocate there, and communicate. Um, what was your question?
it kind of just the how do you discern like what is your MG
Okay,
versus like
got
what you
it.
put. Sometimes I feel like rare disease
Yeah,
patients kind of put things in it like the trash can of like this is all the same
yes,
condition.
I
And how
do,
do you
and I do
discern?
see that. I do.
Yes.
I love that on the online boards. That's my favorite thing on the online boards is,
Hmm.
hey, my toe really hurts. I stubbed it against the door. Do you think it's my MG? I'm being, I see this on the MG boards. I don't
Yes.
know if it's the same on the LEMS boards, but I'm like, no, dude, you stubbed your toe. That's why your toe hurts. Don't blame everything on the condition. So that's a great thing. Know your condition inside and out. Know your body inside and out. LEMS is in the myasthenic conditions, they are hallmarked by fatigable weakness. So weakness that change, weakness that fluctuates. So with LEMS specifically, right, initially you start moving and you get that surge of strength and then it plateaus off and then it fatigues out. And you might go up and down, right? That's LEMS. If it is weak and never surges and never, doesn't really get, but that's something else,
Hmm.
right? If you have, go back to the hip pain question. If you're having pain and you are having a worse day, which is making you use more compensations when you walk, right? And your pain goes up, I would associate that with LEMS. If it doesn't matter if you're having a good LEMS day or a bad LEMS day and your knee is still killing you and your hip is still killing you, it might be contributed to by LEMS, but it's not following LEMS. So that is how I would distinguish.
That's
And
great.
bottom line though is if it's limiting you,
Hmm.
whether it's associated with LEMS or not, if it's limiting you, get it taken care of.
Yeah, that's wonderful notes. I see a lot of stuff in the chats about talking, their physical therapist kind of has them at that fatigue level. And I did just want to put a closing note that we are going to work on some handouts and some information you can take to your physical therapist. We will have Dr. Plowman look those over before we send them out. But we'll record this so that you can share with your physical therapist if you'd like. But thank you so much, Dr. Plowman, for
Can
being
I
our
can I
first. Oh,
comment on that?
yes,
Sorry,
please. Yes,
if your
no.
PT is pushing you to fatigue, communicate, be the
Mhm.
squeaky wheel, and say, no, we need to stay at the 4 to 5 RPE. I need to stay below the fatigue threshold, or it is going to flare my condition up.
And they're going to wonder where you learned your RPE.
Yeah.
They're
Yeah.
going to, what
Speak
a,
their language,
yes,
right?
yes.
And then use the color code, right? I'm
Hmm.
green, I'm yellow, I'm starting to have increased symptoms. We need to draw this back. We need to break this into smaller sets. We need to rest, etc. Because myasthenic muscles don't respond like everybody else's muscles. Everybody else's muscles, yes, you want to push to fatigue because that's where you get muscle growth. You push our muscles to fatigue, you're going to flare us up.
Yep. Perfect.
Be the squeaky wheel.
Wonderful. Well, we'll make sure to have some handouts that you can add to your squeakiness at your next piece. But thank you so much for being our first LEMS Learns speaker. It was a
Thank you for
wonderfully,
having me.
yeah, just full of so much great information. And we will see you all soon. Thank you so much.